Hey everyone, thank you so much for joining us. My name is Chris Mayer, and I'm the Clinical Director of Crisis at Trilogy Behavioral Health. So we're based right here in Rogers Park, and we have a mobile crisis response team that started in January. So our talk today is kind of focusing on, what that experience has been like, and then overall statewide and national trends. So I'll also pass off to Sarah.
Hi, I'm Sarah Fletcher. I'm our Executive Clinical Director at Trilogy. Have been there for about 13 years, but working in the field for about 20. And I oversee all of our outreach programs, so our ACT and CST teams kind of across the city, as well as other stuff. So it's great to be here today. Thank you all.
So we were thinking it would be great to get a sense of sort of like what people's connection to the topic is. So I was wondering if people are comfortable, if we could kind of go around and have everyone say their name and sort of what their interest is in crisis care as a general topic. So maybe I can start off with Mark, if I can put you on the spot, and then you can pass it to someone else.
Yeah, sure. Good morning, and thank you for being here. My name is Mark Rafeman. I'm a clinical professor at Loyola School of Law, actually my first week here. I was at Legal Aid Chicago for the last 3 years, working with serving clients who are unhoused, and working a lot with the advocacy group that some of you may be familiar with, Charge, which formed shortly after the pandemic started. Happy to engage in this topic. I think, especially last winter with Omicron, we saw a pretty disastrous, lack of response, unfortunately, from, generally from the city and elsewhere. And, I know myself and others have been trying to figure out, or, talk with the city about how that can be improved. And, I'm happy to learn and be here to learn from you on, how the new mobile crisis is going and how we all can be helpful. Thank you.
Peyton.
Hi, I'm Peyton. I'm an alum of Loyola, and I volunteered for a while on the Loyola hotline for sexual assault survivors, and I'm interested in multiple types of crisis communication and thought I would drop by. Thank you so much for being here.
Thank you. Yasmin.
Good morning. I'm Yasmin. I am a research coordinator here at Curl. And one of the main projects I work on is around domestic violence and the domestic violence court here in Chicago. I've heard a lot about this new hotline, and I'm curious about kind of the connection with how it's being shared with folks and how it's kind of connected with like the police or not, and what that kind of conversation is looking like. So I'm super intrigued about that, and ready to learn from y'all.
Thank you. Jenny.
Hi, my name's Jenny. I'm actually interested in this. I'm running for a position in the city. It's called District Council. I'm not sure if people have heard about it, but it's brand new, and basically it gives communities a voice in what public safety and policing looks like in the neighborhoods. And one of the things that's really important to my slate and myself is to make sure that we think of alternate solutions to public safety aside from policing. So including things like mental health care workers and things like that is part of the solution. And so we know that there's a lot of community who are doing a lot of the important work already, and there's a lot of answers already to creating real public safety in the neighborhoods. So I'm just curious to hear what you guys have all been doing so I can share it more and uplift it in the conversations I've been having. Thank you.
Well, thank you everyone for the introductions. I'm going to go ahead and share our slide deck here, and then we can get started. Great. Well, Sarah will start us off.
All right. So as Chris already kind of mentioned, we're going to be going over sort of what the crisis care expansion has looked like so far, as well as trends that we've seen that kind of led us to where we are today, and then opportunities are coming up. So we want to talk a little bit about what Trilogy is doing in the space and our new alternative crisis response team, talking about the mobile crisis response model and what crisis services have looked like kind of up to now, and then where things are going from here. So when we think about crisis care, I think it's important to think about how we are defining what a crisis is. And I think in the context of this training, we're talking specifically more about mental health crisis, although I think a lot of the crises that we respond to can just be other crises or socioeconomic things that also kind of fit into what a mental health crisis may be. So the way that we think about what a mental health crisis is any experience that someone perceives as being beyond their ability or having the resources to handle. I think it's important to think about crisis in terms of like perspective and what people's personal experience is, because what might feel like a crisis to one person might not to somebody else, and it's really about how they're experiencing that in the moment. It can be a time of intense difficulty, trouble, or danger, so where people are really going through it and don't have kind of the means to feel like they can handle it on their own. I think another important piece to just put out there in terms of thinking about what crisis is that it's a process that really unfolds over time. So it's generally not just a one-time event that we respond to and then it's taken care of, but it's something that sort of has after effects. A lot of times the crisis comes back if we don't find some way of resolving it or helping people have those coping skills to continue to deal with the situation that they're dealing with. So a piece of what we'll be talking about is the importance of crisis services also having a mechanism for follow-up care or warm handoffs, just kind of something that's going to help with that ongoing stabilization piece after like that specific crisis is responded to. So this is just giving some context and history around kind of where things have been at in terms of crisis response to things and where we're at in terms of the nation, in terms of suicide risk and statistics related to that. So from 1999 through 2018, the suicide rate increased by 35%. So it has kind of gone up and currently for people that are in the ages of 10 to 34, suicide is the leading cause of death. So it is something that is kind of a national emergency and has kind of been something that has needed a lot more attention maybe than it's gotten in the past. I feel like in 2019 is kind of when there started to be some more services that were provided or people were just thinking more about suicide as kind of a national crisis and something that needed to be responded to. And so some of these statistics kind of come from 2019. At that point, 61.2 million Americans had a mental illness and or substance use disorder. And there is also approximately one death by suicide every 11 minutes in the US. We also know kind of in the last few years with COVID, the rates of overdose deaths have gone up significantly just in the last 12-month period through April 2021. 100,000 overdose deaths happened in that period. And yeah, and it doesn't seem like it's really slowing down. I feel like there's a lot of things going on across the world, but I think especially in America that are not currently being addressed with the crisis services that we have, which is kind of why a lot of the funding has come out with the 988 rollout. So when we look at historical crisis care or sort of what things have looked like up until now, think some of you kind of mentioned this just in what you were looking for, kind of thinking about in coming to this training today, was that most of the response for crisis, whether that was mental health or other things, really has come from 911 calls. So people calling 911, emergency or police coming out, which a lot of times does result in more unnecessary hospitalizations, or that sort of being really kind of one of the only avenues for people to receive care, is to go through the emergency room, kind of go through the process of being hospitalized in order to maybe get linked with care from there. And that just really hasn't been working, which is kind of why we're looking at sort of the processes that we have now. However, there have been some mobile crisis programs that do go back as far as the 70s. So it's not a new thing kind of as a whole. However, historically, there's not been much linkage of different mobile crisis programs across cities or states, or definitely not nationally, where sometimes it works well in like one small community, but it's not really linked to things outside of that. So this is just kind of giving some more historical context around how community mental health centers have kind of received funding or developed in terms of like what the focus has been kind of since the 60s. So many of you may be familiar with the Community Mental Health Act that was passed by Kennedy in 1963. It was really the big push for folks to be kind of more independent and outside of institutionalized settings. Before that time, most of the funding kind of went to state hospitals. And so most folks that had mental health issues, if they weren't able to sort of manage at home with their family, that was sort of the other place that they went, and they kind of just stayed there. So there's a big push for folks to be able to move out and have more of that independence. But then kind of as time went on, I think especially in the state of Illinois, a lot of those folks ended up in kind of nursing home or skilled nursing facilities. And it was kind of a similar situation in some ways, where just there wasn't enough housing for folks to get that wraparound care. And so in 2010, the Williams and Colbert consent decrees kind of went into effect in Illinois, which was really where the state of Illinois got sued for the amount of folks that were kind of warehoused in more of these nursing facilities. And so there's been a big push for community mental health centers to work with these folks to move them out of the facilities into the community and kind of provide that wraparound care there. And so currently a lot of the community mental health system is organized around that kind of funding, and where a lot of the Department of Mental Health resources have gone is into those resources to kind of serve those populations. And I think in some ways that's been good, because those are some of the highest need individuals, but then it's not left a lot of funding or context and resources for a crisis, kind of developing a crisis program. I think that has kind of taken away from the ability of the system as a whole to maintain responsiveness and open capacity for emergent needs. And so that's kind of where we're at now, and the rollout of 988 is kind of helping to fill in some of those gaps that have historically been there, especially in the community mental health realm. Oh, Chris, I think you're on mute.
So nationally, as well as in Illinois, a lot of the crisis programs that are being implemented follow SAMHSA's recommendation for the ideal crisis care continuum. And so SAMHSA's recommendation has sort of 3 prongs to it that are meant to fit together to create this sort of seamless crisis system. So the first prong recommended by SAMHSA is crisis call centers. So that's somewhere that people can call when they're experiencing a crisis to receive support and connection to resources. So under the current implementation, that is what is being implemented as 988. So you all have probably heard about the 988 number that has taken over for the National Suicide Lifeline. There's been, it's been in the media and lots going around on social media. So we will go a little bit more in depth on 988 later, but that is sort of that first prong of how SAMHSA sees the ideal crisis care continuum. That second prong then is mobile response teams. So the idea is that when the crisis call center receives a call, if it's something that is emergent and needs immediate in-person response in the community, they can then contact mobile response teams who are then able to go support the individual wherever they might be. And so one important part of that as well is that these teams are 24/7, 365 and can respond whenever and wherever it's needed, because crises don't, follow business hours. So in Illinois, that is being implemented as what's called Program 590, which is the program that we're a part of, which creates a network of mobile crisis providers throughout the state. So once this is fully implemented, in theory, every part of the state of Illinois should have access to a mobile crisis team or multiple mobile crisis teams. The third prong then of the SAMHSA continuum is stabilization facilities. And so this is the piece that is most lacking so far, but we are hearing a lot about them coming more down the line. Crisis stabilization facilities are site-based programs that people can go that are sort of an intermediate step between a mobile response team and a hospitalization. So it's somewhere that is a safe place. People can get some sleep. They can access providers, both, like social work type providers as well as medical providers. They can receive medications. So it's really that increased level of care and support while still not leading to a full hospitalization. So a lot of times they're referred to as 23-hour facilities, meaning that they're not, multiple days. It's not a shelter, but it's somewhere that someone can go for, up to a day at a time. And then if further care is really needed at that point, that's where an inpatient admission would really start to be looked at. The one thing that Illinois does have a good system for is living room programs, which are similar in some ways to stabilization facilities. So living rooms are sort of like relaxed crisis settings where people can go that are comfortable and safe, that are staffed by people with their own experience with the mental health system. So in some ways, these meet some of the needs of stabilization facilities for the crisis care continuum, but one big sort of lacking piece is that people, can't sleep there, can't get rest, as well as there's usually not, medical staff there. So like medications or other more medicalized pieces don't really fit into that. So this is a big, I think, area of advocacy looking at the next few years, that we really need to see an increase in stabilization facilities if this continuum is really going to work. So a few alternative models different than the SAMHSA model. One is co-response type models. So this is where social workers go out with police together to crisis calls. So with the SAMHSA model and with Trilogy's crisis team, we are a solo response model. We don't go out with police as a norm. We go out, alone and meet with people in the community. So co-response models are where people, police and mental health professionals work together. And some examples of that in our area are the City of Chicago pilot, the CARE team, as well as the Cook County Sheriff co-response pilot. Another model is the sort of police-only model of crisis intervention officers. So that's something that we have in Chicago as well, but then obviously by nature includes only interactions with police. There are also some programs that include a paramedic and a social worker or paramedic nurse, different combinations like that. So some examples, one of the City of Chicago pilot programs has a paramedic on it. So that one is the one that's based in the southwest part of the city, as well as the Cahoots program in Oregon includes a paramedic. So this provides some additional support for sort of physical health conditions that may be affecting the crisis that someone's experiencing when the crisis team comes out. And then another model is sort of actual public service, government provided mobile crisis. So some counties in Wisconsin have this, as well as other parts of the country. So I think one topic of discussion that there's been is sort of whether mobile crisis should be a true public service, or like it is currently in Illinois, a network of different nonprofits that are part of this program to provide this service. So a little bit about Trilogy as an organization. So we're a community mental health center, and we've been in operation for over 50 years. We're based originally in Rogers Park, but we offer services throughout the whole city, as well as some first-ring suburbs. Our largest programs are called Assertive Community Treatment and Community Support Team, which are high-intensity outreach mental health services. So these are long-term wraparound care programs that are really meant to help people like manage their health and mental health in the community, to help them live independently and stay out of the facilities that Sarah was talking about before. So they're really, really important programs. You know, as we look forward for like the mental health system, we'll really want to see the crisis care system and outreach programs like working together closely, and hopefully there can be increased funding opportunities to increase capacity of those types of programs to connect crisis clients to. A few other programs that we have an integrated health clinic with primary and psych care, homeless outreach team, outpatient therapy, residential groups, a drop-in center, a reentry program with the Illinois Department of Corrections, and a few other specialized programs. So pretty wide array of services. So what does our crisis team actually look like? Trilogy covers Rogers Park, West Ridge, Edgewater, Uptown, Evanston, and Skokie. So it's not a huge area, but also sizable for this type of service. And we chose those areas because we wanted to really provide like really robust services to a smaller area than our full agency service area. We didn't think it was possible to cover that much area and staff that. And we really have the longest history and connection in those communities. So our services are available 24/7, 365 to anyone, regardless of insurance status, income, documentation status. As long as you're a human and you're in one of those neighborhoods, you can receive our services. So what actually happens on a call? What happens if someone were to call our crisis line? So when someone calls our crisis line, they will first talk to a crisis worker who will, provide initial phone support as well as get information on what's going on. If the person does want to meet with us in person in the community, we will respond in pairs to go meet with the person. And so that is part of the SAMHSA model that includes one person of the pair being a sort of traditionally trained or credentialed crisis counselor, and one person being what's called a peer engagement specialist, who is someone who's working from a place of more lived experience to work together and hit those different angles. So our staff are located out of our main location in Rogers Park. And like I mentioned, when a call comes in, we triage information, provide initial risk assessment, and then dispatch a team to go out and meet with someone. So again, like I mentioned, we are not a co-response model, but we do sometimes seek support and collaboration with police when there appears to be significant, like immediate physical risk to either staff or the client or family, anyone in the community. So we work with the Evanston Police and Skokie Police, as well as with the CIT team at the Chicago Police. They send us referrals, and then we occasionally call them when we need support for a higher risk call. So kind of a breakdown of where our calls come from. So the vast majority of our calls come from Evanston and Rogers Park. So I don't think this is sort of reflective of need, more sort of like the engagement of those communities, as well as our, like the level of our history and sort of footprint in those communities. So They make up the vast majority. There's a really wide variety of reasons why people call. So as you can see, the most common are like mania or psychosis and depression or suicidal ideation. But we also get a number of calls for wellness checks, substance use and recent traumatic events, housing crises, domestic violence, anxiety, as well as like aggressive public behavior that seems to be rooted in a mental health crisis of some kind. There are also a lot of different stakeholders that may call our crisis line. So someone can call our crisis line directly for themselves, as well as a third party can call on behalf of someone. So over a third are people who do call the crisis line for themselves. We have a lot of family members who also call on behalf of loved ones, and then we can kind of coordinate and see if we can engage the individual to being open to meeting with us. We receive a fair number of referrals from police. Evanston police have been especially sort of committed to making those referrals and sort of committed to that engagement, and us being really the people to take lead on mental health calls as opposed to police. Healthcare or social service providers are also a big source of referrals, as well as general community members, alder people and ward offices, as well, and then 988. So as you can see, 988 is still relatively new, but we're receiving fairly few calls from 988. So they're definitely still sort of building up their caller base as well as their protocol and systems for referrals. So almost all of our calls come to our direct hotline as opposed to the 988 national crisis line. As Sarah mentioned earlier on, we also do provide a lot of follow-up services to make sure that we're providing support for that sort of full crisis episode as opposed to just like a one-time event. So we can meet with people, as often as daily, or even a few times we've met with people multiple times within the same day to provide ongoing support, based on their level of need. We provide short-term case management, like applying for Medicaid, adding to housing wait lists, care coordination and warm handoffs to primary care, psychiatry, other behavioral health and physical health services, peer support counseling, connection with legal aid, a lot of work with family members, as well as access to our drop-in center, which is based out of our Rogers Park location. So just kind of a quick word on community engagement. So we've been really trying to focus on this as we get going to make sure that everyone is aware of the program and that we're sort of connecting with the different systems that people experiencing crisis end up sort of interacting with. So what that has looked like, we've done door-to-door engagement with different business owners along certain business corridors where, stuff might come up with people experiencing crisis, collaboration with different nonprofits and healthcare organizations, ongoing communication with ward offices and police, as well as Evanston City Council, and then direct community engagement. So some of you may have even seen us at different neighborhood events, like ward meetings or resource fairs. So just trying to reach people directly as well. So I'll turn it over to Sarah then for some larger national trends.
So I think when we're thinking about where things are going in terms of crisis care nationally, the mobile crisis response is a big part of that conversation. And largely that's come about as a response to police violence and increased mental health struggles during the pandemic. So we know kind of with COVID throughout the last couple of years, there's been quite a few different instances that have happened that have really highlighted the fact that our current crisis system is not working, and that just having police respond to mental health crises is often not the best response, or not kind of what is needed. And so that mobile crisis piece is a big part of, I think, what hopefully will make this new crisis care system really work in a different way, and having different resources than we have. So there's a couple of different legislative policy changes that have really created this opportunity for change. A big one is the 988 one that we have talked about and I'll continue to talk about. And then also the Bipartisan Safer Communities Act. Talking about that first, the Bipartisan Safer Communities Act kind of is what is putting a lot of funding into a couple of different systems that are kind of have been developed or in the process of being developed specifically more for that community mental health response to crisis and other resources around just mental health resources. So the CCBHC, or Certified Community Behavioral Health Clinic, was initially a pilot program where a couple of states were chosen to try out this new way of providing community mental health that has now expanded. Illinois was not one of those initial pilot states. And I feel like Illinois still got a ways to go in terms of developing how folks with Medicaid, how it's going to work with that. So there's not a ton of CCBHCs currently in Illinois, but I feel like it's something that's coming and probably going to grow in the next couple of years as the state's able to kind of figure out that Medicaid piece. But CCBHCs are similar to kind of the idea of FQHCs, which is federally qualified health centers, in the way that they're set up, where that was more specifically for like medical providers. The CCBHC is kind of specifically more for community behavioral health needs. And the idea is kind of that the organizations are set up as like a one-stop shop that are able to provide community mental health services for anybody, you know, kind of all ages, all demographics, kind of have the specialties and expertise for a lot of different populations, where folks are able to kind of come in and get that full continuum of services there. One of the things that is a requirement to become a CCBHC is to have that 24/7 mobile crisis response. So yeah, so I think that's something that is coming, and hopefully will be a great way for folks to be able to have greater access to quality mental health care. Another big project that a lot of money is going into is supporting community and first responders mental health training. So making sure that folks that are out on the front lines responding to crises out in the community have that mental health training and are able to kind of recognize what's going on and get the right people involved. And then the implementation of the 988 Suicide and Crisis Lifeline is where a lot of that funding is going, and will continue to get developed as that grows, and that crisis service and the crisis services are kind of developed to where they need to be to make that work. And then the last one is really increasing the mental health workforce pipeline. I think this is something we're seeing across a lot of different systems and areas, is just kind of a need for more of a workforce to meet the needs of folks. And I think especially in the community mental health world, it's something that has been a huge struggle, is just being able to recruit and maintain or retain workers to be able to do this work. I want to shift to talk specifically about the 988 Crisis Lifeline. I think this is something that people have had a lot of questions about. And I think that there's been sort of some distrust of the system around it. And so we're hoping we can kind of answer questions that people might have specifically about that. But 988 is the new national mental health crisis line that anyone can call when in crisis to receive support and be linked to services. So it's taking the place of the National Suicide Lifeline number. Is kind of now getting shifted over into 988. The idea is that that's like an easier thing for people to remember, and hopefully kind of becomes like the 911 of mental health response across the nation. So right now in Illinois, if a crisis warrants that crisis mobile response, when someone calls 988, then the 988 callers will be linked to someone like Trilogy, a mobile crisis response team, for them to then go out and provide that immediate hands-on support. So it kind of gets routed through 988 to specific mobile crisis response teams to be able to go out and provide that support. this is kind of just like a timeline of where we're at now and kind of where we've come from in terms of getting to rolling out this whole 988 national hotline. So in 2018, the National Suicide Hotline Improvement Act was kind of put out there, and there was a feasibility study into creating 988. So I feel like the National Suicide Hotline's kind of been out there for a while and was a response to some of those other stats that we talked about earlier in terms of just needing more of a response to current suicide rates, and realizing that kind of what we had wasn't enough. And so that was developed, but then it was sort of like, hey, this isn't really enough. And our suicide rates are still pretty high. So in 2020, the National Suicide Hotline Designation Act was put out there, and it reserves 988 specifically for that crisis line use. In 2021, the state 988 funding was released, and then earlier this year, 988 was implemented. It's not kind of fully out there, kind of where it hopefully is going, where there are plans kind of into, you know, the next 5 years and beyond around what SAMHSA is really hoping will happen with that 988 number. So these are some goals that they have around that. So hopefully by 2023, 90% of those 988 calls that are answered will be answered in state. Right now, there's still a lot of development around what those networks look like. Still a lot of places that just don't really have any crisis response set up now. So there's a lot of resources and time and effort that still has to go into just developing those networks in a lot of places. Hoping that by 2025, 80% of those individuals calling 988 will have access to that mobile crisis response. And I think that's really a huge piece of where it needs to get, I think, to actually be effective and have less of that just police only response, where there can be mental health professionals and others involved when there is that mental health crisis. And then by 2027, the hope is that 80% of those folks calling will also have access to crisis stabilization facilities. So that's kind of what Chris was talking about earlier, is just kind of the need for a really robust system in terms of what crisis resources are available when people are calling, to really be able to meet the needs of those that are calling. Oh, you got on mute again. Sorry, Chris.
There we go. Sorry about that. So moving more from nationally to what implementation has looked like in Illinois. So in early 2021, the SESA Act was passed, that was written in collaboration with Access Living, and is what sort of led to these programs. So it describes a universal system of emergency mental health response provided by community agencies. So very soon after that, the state sort of surprised providers who were part of an old program called Program 580, which means maintain telephonic crisis lines, by eliminating that program, but then creating Program 590 that leads to these mobile response programs. And then again, very soon after that, 988 was rolled out in Illinois. SESA was finally signed into law by Governor Pritzker in August of 21. And then projected early next year, the SESA regional advisory groups will establish protocol for collaboration between 911 response teams and police. And so what that means is that after that process concludes, when someone calls 911 with a mental health crisis, they will be automatically diverted directly to mobile response teams if there isn't a need for law enforcement response. So right now, people mainly access us through our crisis line and through 988, but the way the SESA law is written, there will be sort of the assumption that any mental health call goes to mobile crisis, unless mobile crisis requests law enforcement support. And so why we, spent so much time going over these dates nationally in Illinois is just to show how short a timeline all these like complicated interconnection actions have been taken federally and in state. So there's been a fair amount of sort of critique, both federally as well as state government, in some of this rollout. So, and while, we do have some advocacy points and share certain thoughts of how things could be done differently or could have been smoother, we just want to sort of set that perspective that nationally and in state, they really acted in a like time limited way and saw this opportunity and made it happen. And it's something that has needed to happen for a long time. So we just want to kind of, give that perspective that it's really kind of incredible that we are where we are today. So a little more in depth on the CESA legislation. So CESA directs 911, 311, and other emergency response centers to transfer calls seeking mental and behavioral health support to the state's 988 number, unless there's sort of true criminal activity. And in general, CESA prohibits police from responding to a call unless we say that we are not comfortable with it and the risk is too high.
So just want to give an overview of kind of where we are now with all of these different initiatives that are getting rolled out. As Chris said, I feel like there's a lot that's happened in a short amount of time, but also a lot that still needs to happen, I think, in order for the full crisis services to be where they need to be in a way that can be most effective. So currently 988 is fully functioning. All of those crisis centers where they used to get the calls for the National Suicide Lifelines have now been switched over to 988, and people are able to call 988 and it goes to the call centers. There are over 60 organizations throughout Illinois that are in various stages of implementing that mobile crisis response team. So even in Chicago, there are a lot of different organizations that are working within that 590 grant that Chris mentioned earlier, but I feel like we're all kind of in different stages in terms of what that looks like. Some that are kind of not every day yet, some that are still maybe kind of just during business hours. So there's still some places that need to get ramped up in order to like fully get to that 24/7, 365 ability to respond. And then in Illinois, also regional advisory committees have not been fully convened. So organizations continue to receive referrals through our own crisis lines and 988 until that process is completed. So we are, as Chris showed, there's that slide that kind of has all of the different places where we're getting referrals in. And until that's kind of fully done, that will continue. And then at some point, once that 988 process is completed, the 911 will kind of be a point where call diversions can start from that period of time as well. This is just kind of a chart to be able to see what it has looked like, I guess, with our crisis team and kind of all of the different things that are impacting crisis response and what all kind of has gone into it. So we have our crisis team, but then we're kind of responding to a lot of different systems, and a lot of different systems go into what we are able to do. So there's the state and federal and local policies that impact kind of what our program is supposed to look like and how we're rolling things out and the speed of that and what we can and can't do. And there's still kind of within the CESA process stuff that's getting worked out in terms of what is the role of the police, what's the role of the crisis response and mental health professionals. So there's still some of that in Illinois that's getting developed that will impact kind of what the services look like in an ongoing way. And then coordination with public entities. So we are working with a lot of the different offices and councils kind of throughout the neighborhoods that we work in. So as Chris said, we've had a lot of involvement and coordination with Evanston Police Department, some discussions and coordination with CPD, really trying to work as much as we can with the different police departments and developing those relationships. We feel like that's a really important piece of making the crisis responses work. Also working a lot with the Alderman office is Maria Haddon has been great in terms of that. But yeah, just really wanting to work together as much as we can to make this work. And then coordination with different healthcare systems. So that includes hospitals, outpatient healthcare, FQHCs, shelters, just kind of all of the different pieces that are currently there for the healthcare system, making sure that they are aware of what crisis services exist and figuring out how we can best work together with them. We have our own organizational issues kind of within Trilogy and figuring out, you know, staffing stuff and making sure that we're trying to support staff in the best way that we can to deal with staff burnout. And, you know, it's a high stress job. So working with folks within that, as well as response to EMS and then community engagement. So kind of events like this, being able to kind of make sure that people have information that is right and consistent around 988 and talking about what the aims of our crisis program as well as 988 as a whole really is. Been going to a lot of different engagement events throughout our different neighborhoods that we're in, making sure that people again are aware of the crisis response team and the 988 rollout as a whole. Now this is kind of small for people to be able to see, but I think it's just a good sort of picture to be able to see all of the different coverage of neighborhoods, even just within the city of Chicago. I mean, and to me, it's like when I think about the state of Illinois as a whole and like that having to sort of get divided up for different people that are responding to 988 or other crisis calls, that it really is, it's a lot of work that goes into like who's going to cover each neighborhood. Do they have the ability to provide that mobile crisis response? So this just is kind of a breakdown of the different organizations currently that are assigned to different neighborhoods throughout Chicago. So as Chris said, Trilogy is currently covering Rogers Park, West Ridge, Skokie, Uptown, Edgewater, and Evanston are kind of our neighborhoods. And there is a little bit of crossover with some of the other agencies within some of those neighborhoods as well.
So moving on to some of the sort of opportunities and threats that we see as this sort of large scale expansion is happening. I think a lot of people see the opportunities very easily, you know, reduced traumatization of people experiencing crisis, greater access to actual evidence-based crisis care, reduction in unnecessary hospitalizations and criminal justice involvement, reduction in potential police violence, as well as greater collaboration between community mental health agencies and public entities. And then just a safety net for access to care for all individuals. So doesn't matter if you have no insurance, doesn't matter if you're undocumented, you know, every individual can have immediate access to mental health care. Some of those threats, though, that we see that, you know, really we feel like need to be addressed in an intentional way if this is going to work on, you know, a national scale. Staffing, you know, both the short term and long term, you know, viability. It's not a large percent of the population of people who want to do this very specific type of work. It's difficult work. You know, it's not even a lot of people who were otherwise working in community mental health who are wanting to do this. So sort of where are we going to get all the people necessary to do this on a national level? And then even for the people who do love it, you know, that the burnout, you know, concern about safety risks, those are things that, you know, are going to have to be acknowledged. we're imagining that there will probably be organizations who drop out of programs like this over time. So what's going to happen when an organization drops out and says they're no longer able to, cover that area, is something that we really think needs to be addressed, and there needs to be a strong plan for, so it doesn't just get pushed onto whatever the next closest agency is, who may not be, have the capacity to cover that whole other area. There's also no way to predict volume. So there's no metric that is comparable for what sort of like the long-term volume of calls will be. We can't take it just from 911 calls. We can't take it just from suicide lifeline calls. So sort of creating a whole system around something that there's no sort of metric to predict off of is very difficult. Funding difficulties, perpetual issue with mental health and social services, as well as lack of direction from different state divisions. So, for example, with our program, the program is run through the Division of Mental Health, but the grant funding from Division of Mental Health only partially funds the program, and then the rest is funded through Medicaid billing. But those are different state agencies who have different views of what the program looks like and different, rules and stuff. And so that sort of, leads to difficulty and is difficult to understand for providers. Lack of crisis stabilization facilities, like we mentioned. So really the whole third tier of the SAMHSA model is missing. And then the last thing is sort of this one part of SESA that speaks to involuntary hospitalization. So the SESA bill states that mobile crisis providers should be unable to engage in involuntary hospitalization because it hurts the sort of rapport with the people we're working with. And so we 100% agree with that in philosophy, and we do not participate in involuntary hospitalization if it's at all possible. But there's concern because we have licensure and professional responsibilities and sort of like legal precedent that requires us to take certain actions if someone is a very immediate, risk to themselves or others. And for us, we define that threshold sort of like as strongly as we can, meaning that we're not going to, even consider engaging that just because someone says they're feeling suicidal. It's really like it's to the point where something is going to happen if we don't provide this intervention, within the next 24 hours. And so there's a lot of concern from providers that if that is not allowed, eventually what really happens is that those requirements are still there. The difference is that police will be the ones making those clinical decisions as opposed to mental health professionals. So while we entirely agree with it in philosophy, the sort of unintended consequence is actually worse in the end, in that those same decisions need to be made, but now they're being made by police as opposed to mental health. And yeah, that's sort of all we had. So we wanted to open up for questions and comments. Our crisis line number is on here, so anyone can access us for any reason.
Great, thank you so much, Chris and Sarah. Yeah, let's open this up for questions. Does anybody want to get us started?
I have a question.
Oh, go ahead, Jenny, go ahead.
What has the police response been to your teams? Are they happy to work with you guys? What's your feeling on that?
Overall, definitely. So some of the suburban agencies have been sort of easier to engage with because of the scale. And so Evanston, for example, the relationship has been great. Officers always are very, thankful and say they appreciate having us, really take lead when they redirect 911 calls to us, so that they can, focus on law enforcement, and we can do what we do. it's been more difficult with CPD, but I don't think that comes from like a lack of willingness. It's just such a behemoth organization, and they really need to wait for the guidance to come down from the state and from the city on what that collaboration should look like. So we work closely with the CIT program, the DOCS program, and that relationship is really strong, but it's still a sort of remains to be seen what the overall collaboration will look like.
Thank you. I'd be curious talking with you later, Chris, about like just advocacy efforts for making that happen more seamlessly in Chicago.
Yeah, absolutely. I can put my info in the chat here.
Great, thank you.
Yeah, on that point, and Chris, you had mentioned advocacy efforts. Like, is there, I guess, like a focus point or a central point of an organization leading advocacy towards, you know, ensuring that that third prong, the institutional facilities are in place, and other concerns that you see in your work?
So I know the county has had some discussions about the county potentially playing a role in funding crisis stabilization facilities. In terms of specific organizations, CEBA, which is sort of like the mental health trade organization for Illinois, they've definitely been a great advocate and ally in sort of advocating with the state for the mobile crisis providers and the system overall. That's sort of what comes to mind initially.
Yeah, I'm thinking in terms of like, if, you know, people who were less familiar with this world and wanted to get involved and wanted to advocate, would CEBA be a good place to point them to get involved, or are there other places that come to mind?
I think I would probably say your ward offices would be the best place. I think they have been pretty active and sort of can direct people based on what community they live in, sort of who would be best to advocate directly to and what that looks like for that neighborhood.
So the alderman office directly, they should, yeah, okay. Thank you. Great presentation.
Teresa, I want to go ahead and just give voice. Jonathan, our colleague Jonathan Singer had to leave, but he had asked early, you know, in the chat about 988 is 911 under a different name, is what he's been hearing from some folks. Any sense on how many municipalities are using 911 or the local police in whatever form as the way to handle the urgent crisis calls to 988? Any sense of how that's all rolling out statewide?
Yeah, so that's been one of the sort of most significant misperceptions that we've seen going around social media and stuff. And so when someone calls 988, for one, you do not have to share your name or your location, and 988 cannot access the location that you're calling from, which is something else that's been going around. And so the only time where 988 would make a call to 911 is if there is an attempt already in progress. So like if someone says they just swallowed a large number of pills or something like that, 988 would call 911 in that situation, but that is the sole sort of like risk threshold where 911 would be involved. 911 also does not have access to listen to 988 calls, which is something else that we've heard. 988 is completely confidential. It's a crisis worker who answers the phone. HIPAA is in effect with those calls, and so calls also won't be transferred to mobile crisis without someone's consent. So when someone calls 988, it's not like if it's at a certain level, they're going to thrust this on you. It's completely up to what an individual is looking for support.
Thanks. It's fascinating because I think I was saying to Meredith, who's here in the presentation room with me, but I still hear, which is good, I hear primarily 988 is suicide prevention, and that is a fabulous message. But if it's being reduced to it's only about suicide prevention, however important that is, and not just sort of a more particularly locally based crisis response plan and services. It's just I worry that it's getting those sort of fuller services that you all are offering and talking about kind of get lost in the shuffle. So I guess my question to you, and I kind of having been in similar conversations over the years, I think I know the answer to it. How is PR going? Right, just straight up, how are you getting word out? Is that, and I don't mean it like what function, but like what are the struggles? What are the solutions? What are the dreams about how to get the full message out to all sorts of folks? And how could we help?
So I think, that's really happening on a few different levels. So like SAMHSA is really taking the lead on getting the word out for 988 nationally. And then the state has been releasing a lot of like marketing and stuff as well for 988 in state. And so that's also part of why they changed the name from Suicide Lifeline to 988 Crisis Lifeline, to try to take the focus off of only suicide prevention as the reason for calls. For us, it's really just been trying to think about, okay, what are the different like systems that people in crisis might run into, and then engaging with those systems to make sure that then they can help get the word out to people so that they know. So like we've got info in all the aldermanic newsletters, all the different healthcare organizations, all those different points that people might touch when experiencing crisis. But I mean, I think it's going to be a long-term thing, and a lot of sort of, following through on what's being said. So, when people see that when someone calls, these things don't happen, like it's not that police are showing up without your consent and these other things, then I think it'll be easier to believe, what's being said.
I do wonder though about just in terms of your thought of like what you can do. Like I do wonder within Loyola if there's a way to like incorporate, I don't know, some of this stuff within classes or flyers, or we'd be happy to come talk about it or whatever too. But just I feel like that college community is a huge place too to be able to talk about what it is and what's available. And I don't know exactly kind of where all those places would be even within that system, but I don't know, might be something to think about.
Yeah, we do the research, but we are always happy to connect. And so offline, Teresa and I can dream some dreams with you all and figure out, because I think you're right. I mean, I think, and I think universities are an important institution within communities. Complicated at times, but they are an important institution within these local communities. Obviously, Rogers Park up here, but we have a downtown campus. And then we have plenty of colleagues at plenty of institutions of higher learning here in Chicago. So kind of thinking about maybe using Loyola as a bit of a testing site to sort of say, okay, how might we partner this? Who knows where it might go from there. So we'll talk more.
Yeah, at the law school, there's also a mental health law class, which would tie in very well to this. I mean, it's a lot on involuntary hospitalization, involuntary medication, and students may not get as much exposure as they should to alternatives to that. So I think that would be a great tie-in as well.
And to that point, Mark, I mean, I think there's so many both curricular and co-curricular and extracurricular sort of opportunities, particularly at places like Loyola or Northwestern or USC or UIC that have law schools, schools of social work, schools of medicine, nursing, school of communications might be an interesting partner as well, just to kind of, so not only getting to the student body, student population, but then thinking about how to harness the resources of the universities, plural. So if you can't connect with Mark, we'll connect with Mark, and then we'll connect you to Mark, and all this connecting going on.
So a question from the chat, Yasmin asked if we've been in conversation with any local mutual aid groups. So we have talked to Edgewater Mutual Aid and Westridge Mutual Aid, but I know there are a few others nearby that we have not. So if anyone has any contact info or any ideas, definitely feel free to send to my email because we'd love to get in touch.
Well, speaking of another partnership, I would, one of our former colleagues, Lawrence Benito, is the head of ICER, the Illinois, the umbrella organization for immigrants and refugees here in Illinois. That would be an interesting partnership for you all, and maybe the larger network. That map, Sarah, that you were referencing was pretty impressive. I mean, that's a lot of organizations, but perhaps pulling in ICER is not a bad idea, because then they have their membership group, right? They're an umbrella group, so then they have the other various immigrant and refugee rights membership organizations within their or under their umbrella, under their banner. So again, talking about a way to get the word out to multiple communities as efficiently as possible. This ended up being like a planning session, I feel like, here, which is fine. That's all right.
And then I have a question. So what has it been like for you all to have this all kind of come down from on high? And have you felt you've gotten sufficient support, funding, et cetera? Were you able to hire new staff? Like, what did that all look like for your organization?
And though it's being recorded, we can always edit things out. So please feel free to share whatever truth you wish.
So, I mean, it's a lot of things happening at once, like we were kind of identifying in the timeline. So, I think the state has been very focused on developing these sort of large scale pieces. So some of the providers have felt that the actual providers haven't gotten as much guidance or support as would be ideal. Part of that, though, is that the state has been giving a lot of discretion to providers to do things how they see fit for their communities based on feedback from their community. So that's a positive thing, although also, if you want to look at it a little cynically, is maybe like trying to make saying that they've got bigger things to worry about sound better. But the funding, so this program is the largest funding program now for the state of Illinois Division of Mental Health, and actually is the largest ever. So the investment is very large. I think we have concerns about sustainability, and things are very tight, but there are a lot of conversations happening both in Illinois and nationally about how to make this sustainable, whether it's like a 911 tax similar to the way EMS is funded, or a few other routes. So staffing, I think we feel very lucky. We were one of the first programs to get going, so we were sort of up there before. But if you were to search crisis worker on Indeed or something, you would see 20 organizations trying to hire for that position in the Chicago area. So sort of like the long-term viability is a concern, but we're just so grateful for our team. Everyone is so passionate and committed, and so we're very grateful there. I don't know, Sarah, if there's anything I'm missing that you want to add on.
I think that was most of it. I mean, I will say Chris has done an amazing job with kind of like getting this program up and running. It's a new thing for us to have that like 24/7 coverage, like mobile coverage. We've always had kind of the crisis line to be able to respond telephonically, but I think it's been a challenge, and he's written a lot of like the policies and manuals, and I think it is nice that there are some other states that have had programs that we've been able to sort of like read about or think about, or kind of what would work from those like here. But every state's a little different too. So yeah, I think it's been a lot of work, but I would second what Chris has said around us just feeling really fortunate with the staffing that we have. We've got some really great folks. So,
you know, it strikes me that what we're talking about here is not just a new kind of program, which is a big enough lift to begin with, but really, I think what we're all going for here and these sorts of is kind of changing the way a system or systems work in some fairly significant ways. It's not that this is, you know, the newest idea ever that's never been thought of, but this is, I mean, SAMHSA is taking a new approach and investing in a new way, and the states are in various ways. So when you're talking about that kind of systemic change, you know, there's gonna be growing pains, and it's gonna take some time. And I share your sort of concern for, are we gonna, just as a country, are we gonna continue to invest in this sort of an approach or not? Because to show its worth, it's going to take some time to let the roots sink down and for it to grow a bit. So yeah, here's hoping.
Any other questions or comments? Well, Chris and Sarah, thank you again for coming. This has been very informative, and we will follow up to see how we might be able to be helpful and to partner. Like David said, we're always ready to dream dreams and tilt at windmills and all that kind of fun stuff. So we'll be in touch. And thank you all for coming. You have Chris's email to reach out with any further questions or comments or ideas. And so, yeah, again, thank you very much for being here, and we look forward to seeing you all at the next seminar.
thanks so much.
Thank you both. Thanks, everybody.